glad you joined us here today on this webinar for the Foundation for a Healthy Kentucky. My name is Rochelle Seeger. I'm honored to be working at the Foundation as a Community Health Research Officer here. I work on the Foundation's data initiatives, including KentuckyHealthFacts.org data website, Kentucky Health Issues Poll, the annual telephone poll of Kentucky adults on a variety of health issues that we ask them their opinions on, and that is funded by the Foundation for a Healthy Kentucky and Interact for Health. And also the other part of the work that I do is this webinar and workshop series that we call Health for a Change. I'm so glad that all of you joined us today. Yesterday, the staff of the Foundation for Healthy Kentucky was in Madisonville, Kentucky, and we joined a lot of folks there in person for a community forum and a Health for a Change workshop there. So it was great to see everyone working in that part of Kentucky. If you're logged in through the computer, if you want to chat in to me, the county that you're working or the state that you're working in, I would love to see where everyone is from on our call here today. The Health for a Change series is on our website. So there, healthy-ky.org under the Events tab and Health for a Change, you'll see our upcoming events and also an archive of recordings of the webinars and the slide decks from all the webinars. So you can check that out where you can see slide decks from our previous webinars. And today's slide deck will also be posted there. And I'll send you the link via email. Here's a few of our upcoming events. On June 6th, we'll be in Whitesburg. I'm so excited to go there. Whitesburg, Kentucky, to have a regional health forum and also a workshop, afternoon workshop with Kane, Valerie Horn, and the team there. Thrilled to be in Whitesburg, so please join us. June 19th, we'll have another webinar as part of Health for a Change series with Kentucky Youth Advocates and our Kentucky Federal Partnership Specialist, Michelle Ellison. So hear all of the Kentucky updates on that webinar June 19th. The 26th of June, we'll have another awesome coalition building webinar. So if you're in a health coalition and it's having success or maybe it's flagging and needs a little energizing, please join us on the 26th. And on July 24th, we'll be in Scottsville area and Bowling Green area to have another workshop down there. So I would love to see you in person. Webinar is great fun, but in person is also fantastic. So I see folks on the call from Beverly, Kentucky, awesome. Somerset, Meade County, all right. Greenup, folks in Fayette County, Franklin, Madison, awesome, all from across the state. So thank you very much. Pike, Breckenridge, Henderson, great. So thrilled that you all are joining us today from across Kentucky. The Foundation's work and reports and Health for a Change is all on our website, healthy-ky.org. The Foundation for Healthy Kentucky's mission is to address the unmet health needs of Kentuckians, and the Foundation does its work in three main ways: by developing and influencing policy, improving access to care, reducing health risks and disparities, and promoting health equity as part of our mission. One more announcement before we get this show on the road, because we have two fantastic presenters. Finally, I'd like for you to save the date, November 15th. We will be in person in Erlanger, Kentucky for the Data Forum. I'm thrilled to coordinate that event with my colleagues at Interact for Health. So please save the date for November 15th up in Erlanger, all you data lovers on the call. Or if you're not a data lover, come join us and you can meet a friend in person and learn more about all the great things in health data going on in Kentucky. I'm thrilled to have Dr. Ty Borders here to talk with you about some of the work that he's doing, and he is an endowed chair of rural health policy for the Foundation for Healthy Kentucky and at University of Kentucky. So please welcome Dr. Borders. Go ahead, Dr. Borders.
Thank you for the nice introduction, Rochelle. And I'm calling in from Houston, which is a nice, the nice thing about these webinars is you can be anywhere, of course. So today I'm going to be talking about some of the work we've done in the past couple of years. This is some work I've done with a colleague, Hefe Wen, who's an assistant professor in our Department of Health Management and Policy. And this particular study focuses on medication-assisted treatment among Medicaid enrollees in the state of Kentucky who have an opioid use disorder. So today I'm going to be focusing on a few things. But before, in terms of describing the receipt of treatment for opioid use disorder among Medicaid enrollees, and I know we have a bit of a diverse audience, so I'll talk about the different treatment options, including buprenorphine, methadone, counseling, and then also talk about the fact that counseling is really recommended to be provided in conjunction with buprenorphine, the medication to treat opioid use disorder. So the particular study that we did here in Kentucky, again among Medicaid enrollees, the point of this was to document and look at over time whether people who had an opioid use disorder were receiving more treatment or less treatment, and also to examine whether there were differences in treatment rates across metropolitan and non-metropolitan counties in the state. Before I get into the details of that, though, I'd like to provide a little bit of background about the problem of drug use in the United States and specifically opioid use. So this is a map that I have taken from an article published in JAMA, and this is probably not too surprising to many people on the call. We know that opioid use mortality is a huge problem across many areas of the United States, but especially in eastern Kentucky and West Virginia. So if we look at this map, you can see that the red areas, these are counties. This is shown as county-level mortality rates from drug use disorders in the U.S., and most of these are because of opioid use. But clearly, eastern Kentucky and West Virginia, pockets of Ohio, have a huge problem in terms of opioid use if we look at this indicator of county-level mortality rates. Then there are a few other areas of the country, like in New Mexico and in Oklahoma, where there are pockets of this occurring too. So luckily, I mean, we can try to think about a positive spin to this. There is at least a medication that's available to treat persons who have an opioid use disorder, and that's buprenorphine. Let me back up a little bit. There has been another medication that's been available for much longer, which is methadone. But the problem with methadone is that it requires persons to go to a federally designated or qualified opioid treatment program, and that's a big barrier. People have to go to the methadone clinic to receive their medication, the methadone. Buprenorphine, on the other hand, is a pill, so persons can go to a physician, at least certain types of physicians, which I'll get into in a minute here, and receive a prescription for buprenorphine, just like any other type of prescription. So this has really led to a huge increase in the availability of treatment for opioid use disorder. Again, though, there's some caveats. So not any physician can prescribe buprenorphine. Physicians have to be waivered by the Drug Enforcement Agency at the federal level, and to receive this waiver, they have to be board certified in addiction medicine or psychiatry, or receive 8 hours of training through web-based training or in-person training or some combination thereof. So there are also some other limitations. The 2000 Drug Abuse Treatment Act restricted the prescriptions to only 30 patients per year, which is not very much if we think about this. In 2006, because of this concern about the limitation, an act was passed to raise the limit to 100 patients per year if the provider had treated at least 30 persons in the prior year. And it also expanded eligibility to physician assistants as well as nurse practitioners. Then in 2016, again, because of this concern about the limits and trying to make sure that people who needed treatment can actually obtain it, the Substance Abuse and Mental Health Services Administration issued a ruling that raised the limit to 275 patients. So this is good that the treatment capacity has increased, but on the other hand, there's still concerns about these limitations in terms of the number of patients that a given provider can treat. Just to provide a little bit more background, this is a map that my colleague Hefe Wen and I have created recently. This is showing us distance to the nearest buprenorphine-waivered physician, and the darker blue zip codes indicate that there is closer proximity to at least one waivered physician. The white areas indicate that there's no buprenorphine-waivered physician. I shouldn't say no. There's not one at least within 100 miles. So luckily, it's kind of hard, a little bit dense to look at Kentucky, but clearly most persons in Kentucky live at least, at least within 5-10 miles or so from a buprenorphine-waivered physician. Okay. Another thing I'll add on the next slide is, of course, Kentucky expanded Medicaid, and one of another study which we conducted, I guess, a couple of years ago, we found that nationally that states did expand Medicaid, experienced a pretty significant increase in prescriptions for buprenorphine. So the main conclusion here is that Medicaid expansion has also made a difference in improving access to this medication, which is important because it's pretty costly. It costs about $6,000 for a course of treatment over 1 year. All right, so that's a little bit of background about opioid use disorders and also medication-assisted treatment, at least in terms of buprenorphine. Let me get to the details of the project that we conducted in the state, again, among Medicaid enrollees. So this project included Medicaid fee-for-service and managed care enrollees. We excluded dual-eligible persons from our analysis, in other words, persons who were also on Medicare. And we conducted our analyses based on outpatient, inpatient, and pharmacy administrative claims data for the years 2014 to 2016. We also were able to determine if an individual had a diagnosis of an opioid use disorder by ICD-9 or ICD-10 codes that were indicated in the claims data. And another point I want to make here at the end is we were more interested in focusing on persons who were relatively newly diagnosed. So we had a 120 days negative diagnostic window. In other words, persons could not have had a diagnosis of OUD in the time outside of that window. So in other words, we're really focused on newer cases of opioid use disorder. Another thing I might add, I've been using the term opioid use disorder, so we're not really focused here in our work on persons who may just misuse opioids, such as prescription painkillers or that are opioid-based or heroin, but we're really, the treatment is really focused on persons who meet criteria for an actual disorder, which is defined by the Diagnostic and Statistical Manual criteria for psychiatry. Okay. So in terms of the receipt of medication, again, as part of medication-assisted treatment, we looked at whether persons received buprenorphine and methadone. We also excluded, and I think this is important, a few forms of buprenorphine that are usually prescribed actually for pain management instead of for the treatment of opioid use disorder. Okay, so I mentioned earlier that medication-assisted treatment is really intended not to only include the pill, the buprenorphine. It's also really intended to include counseling because most persons who are misusing and abusing opioids or other substances, they have other things going on in their lives, which leads them to misuse drugs, alcohol, etc. And the pill, the buprenorphine, doesn't really help people improve their coping strategies and learn how to deal with other issues. Another reason counseling is recommended is that the majority of persons who are using opioids are also using other substances for which there's not a medication. The vast majority of drug use disorders have no medication therapy available for treatment. So in other words, the recommendations are that persons need to receive counseling in addition to buprenorphine to deal with these other issues and mental health problems that may be occurring. All right. Most of my work is in the area of rural health, of course, and we were also interested in how treatment rates might vary across metropolitan counties. Metropolitan county is one that has an urbanized area of at least 50,000 persons, and non-metropolitan counties are those counties that do not have an urbanized area with at least 50,000 persons. We also distinguished counties that were adjacent to, non-metro counties that were adjacent to a metro county and those that were not adjacent. This analysis is pretty straightforward. So we estimated the monthly and annual proportions of Medicaid enrollees who had an opioid use disorder diagnosis and the receipt of buprenorphine, methadone, and behavioral health counseling among those persons who had a diagnosis of an OUD. So let's jump to some of the findings. In this slide, and we have to take note of the scale of from 1.5 to 2.10 here on the left. This is showing us the proportion of Medicaid enrollees who have an OUD by year, and these are opioid use disorder. In other words, this is more reflective of the incidence as compared to the prevalence. And it does appear that it's not a significant decline, but there's sort of a slight decline, minor decline in the proportion of individuals who had an OUD. All right. The next slide is showing us the proportion of persons who had, again, a more recent OUD who received treatment. And you can see here that from 2014 to 2016, that the proportion of persons receiving buprenorphine declined, and it declined significantly. So it went from around 40% down to about 30%, which is sort of concern. The proportion of persons that receive counseling may be stable, so we're down between 14 and 16. And then on the upside, though, if we look at the proportion of persons that were receiving buprenorphine who also received counseling, that increased. And I see that as a positive finding here because, again, persons receiving buprenorphine should also be receiving counseling in addition. The next slide is showing us the rates of treatment receipt by metropolitan status. And this might be a little surprising to some persons. Maybe it's a little surprising to me too, to be honest. But we found that if we look here at buprenorphine, that the treatment rates were actually higher, better among persons who lived in non-metropolitan counties, regardless if those were adjacent to a metropolitan county. Same thing for counseling. The treatment rates for counseling were higher among non-metropolitan residents who had an OUD. And if we look at the receipt of counseling among persons who were receiving buprenorphine, those rates were higher among non-metropolitan persons with an OUD also. So what does this mean? I have a few concluding thoughts here. And one thing I'll mention is that it looks like the number of OUD is going a little bit, but it's not significant. You continue to monitor this to determine, if how this is changing. And my guess is that we are really experiencing a decline in opioid use disorders. Another thing that I mentioned is that the receipt of buprenorphine and counseling declined, which is not good. Why is this occurring? I think that one thing that might be occurring is that the treatment capacity is sort of maxed out. Treatment providers are already maxed out in terms of the number of persons they're treating with buprenorphine or counseling, and they just aren't able to take in new providers. There could be some other things going on, though, in terms of policies implemented by the state or by managed care. Could be a decline in the receipt of buprenorphine and counseling among persons that have OUD. On the other hand, again, I mentioned earlier that the quality of care might actually be improving because more people who are receiving buprenorphine are also receiving counseling. And then lastly, this issue of the finding that metropolitan persons with an OUD had worse access, I think is maybe not too surprising if we think about the investments that are occurring, especially from the federal government through HRSA, the Health Resources Administration, really investing quite a bit in treatment access in rural or non-metropolitan areas, what may actually have led to an improvement in access in those communities. Areas. Access backs a little bit because of the differential investment in metropolitan counties, if that makes sense. So that's the end of my talk. I'm happy to turn over the next, turn it over to my colleague Terry Bunn, who will proceed. And then we'll have an opportunity, I think, after Terry talks to have some questions that we can try to respond to. So thank you very much.
Thanks, Ty, for a great presentation. Well, good afternoon. I'm Terry Bunn, Director of the Kentucky Injury Prevention and Research Center. Let me get my slide up here. And I'll be talking to you this afternoon about resources that are available at the Kentucky Injury Prevention and Research Center, or KIPRIC as we call it, for drug overdose prevention. KIPRIC was established in 1994 as a unique collaboration between the University of Kentucky and the Kentucky Department for Public Health to combine both academic research and public health practice in the area of injury prevention. KIPRIC's the bona fide agent of the Kentucky Department for Public Health, and in this role, we can apply for injury prevention grants on behalf of the Department for Public Health. As such, KIPRIC is located within both the State Department for Public Health and the University of Kentucky College of Public Health organizational structures. Typically, research is performed in the laboratory or community setting, and then the study results are used to inform the development and implementation of community practice interventions. This overall is called research to practice, or R2P. At KIPRIC, we routinely and regularly perform community practice and identify through that practice injury prevention needs and gaps. To address those needs and gaps, research studies are then conducted here, and the study results are used to inform the implementation of targeted interventions that gather new evidence and build on the existing evidence base for effectiveness. This is called practice to research to practice, or P2R2P. At KIPRIC, we have multiple externally funded programs to prevent drug overdoses that are considered poisoning injuries, and that's why they're considered injuries, because poisonings are injuries. I'll specifically talk about the resources that are available through our two CDC National Center for Injury Prevention and Control funded programs called the Statewide Drug Overdose Prevention Program and our Enhanced State Opioid Overdose Surveillance Program. Both of those are received as the bona fide agent for the State Department for Public Health. The goals of our statewide drug overdose prevention program are, number one, to enhance the use of the Kentucky Prescription Drug Monitoring Program, called CASPR here, as a public health surveillance system. Number two, to implement community interventions. And number three, to evaluate state-level drug-related policies. I'll begin with a community intervention that we developed here at Kiprick in partnership with the Department for Public Health and the Department of Behavioral Health, Developmental, and Intellectual Disabilities at the State Cabinet for Health and Family Services, and in partnership also with the Kentucky Office of Drug Control Policy located in the Justice and Public Safety Cabinet. FindHelpNow.ky.org is a near real-time substance use disorder treatment facility locator. We spent about a year developing it in 2017 and launched it in February 2018. And it's more than just a listing of all of the substance use disorder treatment facilities in the state. Participating facilities update their opening availability on a daily basis. And this unique feature of FindHelpNow.ky.org helps individuals, family and friends, clinicians, social workers, and peer support specialists rapidly link individuals to treatment based on the individual's needs and preferences when that individual is at that critical stage of readiness. There's over 30 search criteria available to target your search on the website, such as payment ability, whether it's Medicaid, private insurance, or no insurance. We have criteria on concurrent mental health services, whether the facility has a smoking policy, if the individual is a smoker, and whether they provide services for pregnant women, just as a few examples. It also has an information repository tab that provides information on the general or for the general public concerning questions on substance use in general, information for family and friends specifically, information for health professionals and for safety professionals, and also even if you want information on syringe and needle exchange programs. You can also refine your information research on specific topics such as MAT, which Dr. Borders was talking about, including buprenorphine. You can look up even information specific to adolescents or even naloxone, just to name a few of the topics. FindHelpNow.ky.org does not track individuals and doesn't ask for any personal information beyond where you're searching for treatment facilities. For the general population, I think it saves valuable time in seeking treatment facilities with the available openings so that the individuals can get into treatment as soon as possible. And for policymakers, the website, it can provide supplemental information such as treatment facility type, by the location where the search was formed that can help policymakers determine the specific geographical areas of treatment facility type need versus current treatment facility capacity. This slide, I'm not going to talk about it, but it does display, again, I already mentioned, our major partners in the development and implementation of the website. Looking a little bit at the stats right now on the website, as of a couple of weeks ago, over 550 substance use disorder treatment facilities now participate in FindHelpNow.ky.org. And that accounts for about 91% of all of the substance use disorder treatment facilities in the state. We've had over 150,000 total website visits. Over one-half of all the searches are for males with substance use disorders seeking treatment. Over 85,000, actually I think it's closer to 100,000 right now, completed searches have been performed, with almost half by a concerned family member or friend, about 1/3 by a health professional, and 1/4 by individuals themselves. And when we talk about the facilities, The facilities themselves have logged in to update their profiles over 3,000 times. So that's a big hand and congratulations to all of those that are taking the time to do this. Over the next year, we plan to include more MAT providers on the site. Right now, we only have about 49 out of 485 total, or about 10% of all MAT providers in the state that are currently participating on the site. And we also plan to adapt Find Help Now, KY.org, to Recovery Housing Help Now over the next couple of years, so that there's a recovery housing locator available soon to the residents of Kentucky. As well, CDC really likes this website, and other states have shown interest in Find Help Now as a model, and we plan to expand the website to be able to include other states in the next year. This slide shows the facility types that are currently on the website. The largest number of facilities are outpatient facilities that number about 324. The next largest facility type are the MAT facilities, numbering about 195, followed by intensive outpatient facilities numbering about 187. We also have about 91 residential facilities, 56 detox facilities, and 11 inpatient facilities that are participating on the website. This slide shows the landing page for the website. It's really, really easy to use. We've tried to make it as simple as possible to be able to be linked to the facilities as quickly as possible. So we only ask for 5 optional questions that website users can answer. First, they're asked whether they're seeking information for friends, family members, clients, patients, or the individuals themselves. That really helps us to be able to identify and really search or identify the target population that's really intensively using the website. We also ask gender, since some facilities only accept a single gender. Geographical location is also asked so that the search is directed to the geographical area where treatment is desired. The website's also set up where if you want to search for a treatment location that is as far away from you as possible but still within the state, that option's available as well. The treatment facility type is also a search field for individuals to choose whether they want an outpatient, inpatient, or residential facility. And we also ask payment on the website so that if individuals are choosing facilities based on their insurance coverage, the results page will only include those facilities that accept their insurance type. If you look kind of at the bottom of that search box, we also have options available to choose matching facilities if you're pregnant, if you're an adolescent, or if you want a facility based on your gender identity. So there are multiple advantages of the Find Help Now KY.org website, and these include the ability to assess substance use disorder treatment facility opening statewide in a particular slice of time, and to assess the need for specific types of facilities in the state. It also provides the ability for facilities to produce utilization reports that align with SAMHSA reporting regulations so that they don't have to produce separate reports for those reports. There's also about 28 one-page documents in the information tab that are written at a 4th grade reading level on a variety of substance use disorder topics. We've also produced informational brochures on the website if anyone would like to request them. We've produced pocket cards, instructional videos on website used for the general public and for facilities participating in the website. As well, we've also produced a communication guide directed to the patient-clinician relationship on discussing substance use disorders. This is the cover page of the Healthcare Professional Communication Guide. We've received a lot of great feedback on this brochure today, and we'll have these available for downloading for free from the KIPRC website. And this is a slide of the table of contents within that Healthcare Professional Guide so that clinicians can get an idea of what's contained in the brochure. So there's screening for substance use disorders, that's discussed, as well as the stages of change. And those stages of change include pre-contemplation, contemplation, preparation, action, maintenance, and relapse. And we'd be remiss if we also didn't discuss Find Help Now as part of that brochure. We also have the Drug Overdose Technical Assistance Corps. So, I should back up. That was a really, really quick discussion of findhelpnowky.org. Within this grant, we also established the Drug Overdose Technical Assistance Corps to provide drug-related data for local communities and for state policymakers to use for targeting, implementation, and evaluation of interventions, and for policymakers to use for development of new legislation. A lot of people who are individuals that request data from us also use it to evaluate the effectiveness of their implemented policies and programs or regulations at the state and local levels. This is a slide of a county profile that communities can select for their specific county related to drug overdose emergency department visits and inpatient hospitalizations. At the top of the page, you can see that Jefferson County was selected for this profile that's being presented. Information that's included in the county profile is a snapshot of the classes of substances that are involved in drug overdoses. You can see it here, such as, although it may not be very clear to viewers here, but it contains classes such as antidepressants, benzodiazepines, cocaine, heroin, opioids other than heroin, and all other classes of drugs. Of note, the numbers that are displayed here in the county profiles are not mutually exclusive, meaning that some visits or hospitalizations actually contain more than one of the listed substance categories. There are also numbers for specific drug combinations for heroin in combination with other opioids, and for opioids other than heroin in combination with benzodiazepines. County profiles also contain frequencies on non-dependent abuse of drugs, excluding overdoses, as well as for drug dependence. And that's easily available, and these county profiles are on our website under the Data tab. We've also partnered with the Kentucky State Police to establish the Kentucky Substance Use Research and Enforcement Collaborative. This collaborative combines both public health and public safety data so that a more comprehensive picture of substance use and substance use disorder prevention is available to increase the identification of specific substances emerging in substance abuse, and to help target and integrate prevention, treatment, and law enforcement efforts to prevent drug overdoses. This slide is an example from our latest report on meth-related events in Kentucky. You can see here that meth possession citations have significantly increased over the last couple of years, as well as the Kentucky State Police tested laboratory submissions that were positive for meth. Meth trafficking citations also increased, as well as meth-involved deaths. And these reports, the case year reports, are also available for download from the KIPRC website. We also produce downloadable, comprehensive, and highlight reports on drug overdose fatalities. This cover represents a summary highlight report for 2017 drug overdose fatalities. We will be producing the 2018 report here within the next 2 or 3 months. This slide shows a page from the highlight report looking at the number of meth-involved deaths by county. As you can see from the map, there were elevated numbers of meth-involved deaths in Jefferson, Fayette, and Madison counties, as well as in the counties that surround Jefferson County and in counties in northern Kentucky. Also available on the KIPRC website are CASPR quarterly threshold analysis reports. CASPR, like I mentioned, the Prescription Drug Monitoring Program in Kentucky, they produce themselves a quarterly report that's available on their website. Our report takes their report just one step further and further breaks down the data by age, gender, and includes information on rates. This slide from a CASPR threshold report shows the rate of opioid prescription dispensing in Kentucky from the first quarter of 2015 through the fourth quarter of 2017. As you can see from the figure, opioid prescribing rates have significantly decreased over the study period. And actually, they've decreased since about 2012, 2013, when the Massive House Bill 1 was passed in Kentucky that implemented mandated registration and use of CASPR, as well as implementing regulations pertaining to Schedule 2 through Schedule 4 controlled substance prescribing. This slide from a CASPR threshold report shows the Schedule 2 stimulant dispensing rate by age and by gender. The figure shows that the highest Schedule 2 stimulant rate was for male children under 16 years of age, which actually at first was a big surprise to us. But to help explain this result, this category also includes the ADHD drugs that are typically prescribed to teenagers and specifically to males. They more frequently receive these medications. You can also see from this figure that once individuals are about 25 years of age, that there's a flip in the predominant gender being prescribed Schedule 2 stimulant drugs. Females 25 years of age and older then are more frequently prescribed Schedule 2 stimulants compared to males. So I've shown you just some of the resources that are available to local communities, to the state, and to the general public for drug overdose prevention. We also produce other resources pertaining to other injury types, such as pediatric abusive head trauma prevention, teen driving injury prevention, and worker injury prevention, just to name a few of the topic areas. My contact information is listed here, and I'm happy to answer any questions that you have. I'm not sure if it's time for questions or not based on this webinar. So thanks a lot. I'll turn it over to Rochelle now.
Great. Thanks so much, Dr. Borders and Dr. Bunn. A great discussion, and we have loads of time here before the hour ends to answer questions that we've received in. The first one is for Dr. Borders. The question is about the prevalence in metro and non-metro areas. So is there a difference in the treatment for MAT and counseling in those areas? So if you would just go, I'll go back to your slide on that one, if I can find it.
Okay.
Not metro and non-metro. So just give us the summary again of this slide here, and how does that relate to prevalence that we might see in those areas, or have you yet to do that analysis?
So I cannot recall if we found a difference in the in the prevalence of opioid use disorder between metropolitan and non-metropolitan counties. Terry can maybe speak to that. But I think the thing to remember that from one point from this slide is this is treatment received among persons who had an opioid use disorder. So if we think about among those persons, if we want to try to achieve equity of access and really try to improve access overall, then my point would be we need to improve it for metropolitan residents as well as non-metropolitan residents, because these treatment rates are around 40–50% for non-metro residents, at least for buprenorphine, and they're only around 25% for metro residents in terms of receiving buprenorphine. And those treatment rates, in comparison to national estimates, those treatment rates in Kentucky are actually pretty good among Kentucky Medicaid enrollees. But on the other hand, if we compare these treatment rates to, let's say, persons who have cancer, the vast majority of people who have cancer are getting treatment. So overall, we might consider these pretty low. But back to the question, I think if we want to think about equity of access, then we will want to try to make sure that our metropolitan residents are also getting treatment.
Thanks, Dr. Borders. And a related question around the slide, in measuring the access in metro areas and areas across the state, was race included in the analysis, and were there any differences in access to treatment?
Yes, we did look at race, but I don't recall any difference. I'll have to go back and check on that. These are, we did do some additional, more complex analyses. These are, fairly descriptive here. I'll have to go back and check on that, though.
Great, thanks. And I guess this is for Dr. Bunn and Dr. Borders. Besides MAT and counseling, are there other types of programs and services in Kentucky that are offering wraparound services for folks who are have substance disorder? And are there many, and are they included in your websites or in your analysis? So, Dr. Borders, if you want to start with your answer.
Terry may be more knowledgeable about that than I am, but my hunch is that for the most part, when people are going to physicians or nurse practitioners or PAs, if they're receiving buprenorphine, medication-assisted treatment, that those provider clinics, a lot of these are primary care clinics, they're not really in the position to have the resources to provide those types of services. And I don't know as if Medicaid has any special programs to do this either. It's a good question, but I think it's, these are medical care interventions in terms of buprenorphine, and of course the medical care system just doesn't get too involved in those types of wraparound services, unfortunately. But maybe Terry has a different viewpoint.
Yes. When you look at Find Help Now, I just showed the initial landing page. When you get to the results page, on the left-hand side of it, there is a tab which shows, that's only the landing page that showed right now on this slide, but the results page has a whole left side with a number of tabs, and if you look at additional services, if you choose any of those that are desired, then that will display the facilities that offer those additional wraparound services, such as mental health, domestic violence services, health education, anger management, parenting classes. So all of those can be available, and you can really, really narrow down your search for those facilities that offer those additional services when you use Find Help Now.
Great, thanks, Dr. Bond. Another question for you. This wasn't the topic of our webinar, but Is there a difference in evidence-based prevention programs for methamphetamine versus opioid abuse?
Okay, well, I guess the big thing is as far as evidence-based programs in general, you know, this is a fairly new research field, as Dr. Borders can attest to, so there's not a lot of evidence out there. What we do know right now is that MAT is evidence-based. The other evidence-based programs are actually more evidence-based policies at this point. Regarding meth, specifically, I don't know of any specific evidence-based programs out there right now to treat meth addiction, but you know there's a lot of research going on right now, and the evidence is building. What I can do is if this person is interested more in this topic, then I can consult with the CDC and SAMHSA to see if they have anything that they are aware of as far as offering new evidence-based in that area.
Great, thanks so much, Dr. Bunn. We have a few more questions, but before we wrap up for the day, if you would just each of you make a summary, or what's your main concluding point that you want folks to take home that are on this webinar, and then we'll go back to the final questions that are coming in. Go ahead, Dr. Borders. What's your main take-home point for folks who are on our webinar today?
Thank you. So in terms of Medicaid enrollees in Kentucky, I think it's a little concerning that the treatment rates declined over the last few years, or from 2014 to 2016. And I don't really, I don't want to imply that this is Medicaid's fault. I think, as I mentioned earlier, one of the factors that could be contributing to this decline in treatment rates, if we look at buprenorphine specifically, is that the system may be sort of maxed out, as I mentioned earlier. Yes, we have increased the number of physicians who have the waiver to prescribe buprenorphine, but a lot of people who get the waiver are not using it to their full capacity. And then in some cases, there may be persons who are using it to their full capacity, and they have more patients who want treatment, but they're not just able to deliver it because of the federal regulations on the limits in terms of how many patients they can treat.
Thanks, Dr. Borders. And Dr. Bunn, what's your main take-home messages for our audience today?
Okay, well, sorry, you're catching me right when the train's going by.
Okay, Dr. Bunn, you can put it on. Yeah, you can put it on mute, and we'll come back to you in just a moment. I can do my wrap-up things while the train goes by Dr. Bunn's office. Later this afternoon, I will send you a link to the SurveyMonkey, where we would love to get your feedback about today's webinar. That's my little dog on the screen there. It's important for us to hear what you thought about the webinar, what additional questions you have, and for this series that the Foundation for a Healthy Kentucky puts up that we fondly call Health for Change, your ideas for future events just like this. So I would love to hear for that so we can plan great events for the future for all of us. Someone was complimenting your Find Help Now Kentucky website, Dr. Bunn. So if you're available to jump back on the call to give us your concluding point, Dr. Bunn, if the train's passed.
Yeah, well, almost passed, but yeah, no, the main point that I would like people to take away from this is that, yes, as you can see here, I just provided a quick snapshot of the data results that are available for communities to use to target and to evaluate their interventions. We also at the center have experts who can help community coalitions in their strategic planning for drug overdose prevention, as well as sustainability planning. And, pertaining to the one question that a viewer asked, we are developing a toolkit right now of evidence-based interventions for local communities to pick tools from in that toolkit for interventions related to what their data is telling them and where they need to target their efforts.
Great. So a lot of good information there for all of the health advocates out there working on this health issue in Kentucky. Finally, my contact information. I'm here at the Foundation for Healthy Kentucky. I would love to hear from you on the post-event survey that I will send out. As I mentioned, we have great upcoming trainings in June, July, August calendar will be issued soon that we do as part of the Health for a Change series. Those are all on our website, healthy-ky.org. Under the Events tab, I want to thank each of you for being on the call today. We had a huge group of participants who logged into our webinar today to hear from both Dr. Bunn and Dr. Borders, so I'm appreciative of their time and expertise to share with all of us that are working across our Kentucky communities to improve health in our state. Thank you very much for being on the call today. Finally, if you aren't following the Foundation on Twitter or Facebook, you can check us out on our Facebook page, Foundation for Healthy Kentucky, or our Twitter handles HealthyKY, and I also tweet out of Health Facts. So thank you for joining us today. I hope you have a great afternoon, and please complete the post-event survey that I'll send to you later this afternoon. Thanks for being on the call, and thanks so much for Dr. Bunn and Dr. Borders for sharing their work with us.